So I'll next invite Dr. Sudeep Das. I'll expect the speakers to all stay back so that we can have a discussion if time permits. Dr. Sudeep Das is in Ganjam and again leads a hospital, does a lot of high volume work. So Dr. Sudeep will speak on iris hooks, pearls and pitfalls.
Thank you so much, Suven. And I don't have any financial disclosures to make. So coming to the advantages of iris hooks, of course, they are way cheaper than any of the other devices. There's a relatively shorter learning curve compared to the other devices. And it can be used in very shallow ACs also. Normal shallow, yeah, it's possible to use other devices. But why is this not moving? So they can be a little dangerous because you have chances that they'll probably, if they get dislodged and all, they might touch the corneal endothelium. The other advantage is that if you think that there might be some subluxation, you can actually shift the hooks from the pupillary margin to the rexus margin. And of course, this is not ideal, but it's probably a lot of places it's done. You can ETO and re-sterilize them. Disadvantage is that they tend to create sphincter tears and give a slightly irregular pupil postoperatively. And in atrophic iris, they can really tear, up to the limbus. And if you're not careful, you can tear the anterior capsule also, especially if you're using reused hooks, because they open up. They're difficult to use in presence of, in small eyes, it's a bit difficult to use. And they tend to get dislodged. I'll show one of those. But you can sort of cut off the external part beyond the bung, beyond the silicon bung, and they won't get dislodged after that. Then the other thing is the iris is lifted up by these hooks. You can reduce the amount it gets stented up by making the incisions a little posterior. And applying a hook posterior to the phaco wound, you can sort of avoid that. And so one is sort of just behind scleral, as was already shown, to the posterior, to the phaco wound, and then you can use 3 or 4 more iris hooks elsewhere. So this was a post-trabeculectomy patient with a lot of synechiae. And as you can see, I make all the openings before I do anything. So I make my side ports, I make my the incisions for the iris hooks, everything one shot before I have introduced any viscoelastic or anything. And then there's the trypan blue. So I've already made the entry for the iris hook sclerally, and then I actually made the phaco wound anterior to it. So here I'm releasing the synechiae. And if you see I'm using a Sinski, I have absolutely no use for iris repositors or anything like that in my practice. So this is scleral, as you can see. It's going behind the phaco wound. You can make it after making the phaco incision also. So these you can use, these you can see are, obviously you can make out, they have been reused. So they are little open. So when you have something like this, you're a little careful because there are more tendencies to damage. So if you see, I keep them slightly sideways. I don't point them towards the anterior capsule. So they're slightly tilted to the side. So they're not actually engaging the anterior capsule, which is a good idea even in brand new iris hooks. So basically there are 5 iris hooks. This is ideal in complicated cases. And then of course the surgery is very routine. And then implant the IOL of whatever your choice, and then remove the iris hooks. So for removing the iris hooks, basically you disengage it from the iris and rotate it towards the cornea. It sort of almost automatically come out. You don't have to struggle with trying to remove it. So just rotate it over the cornea and it will come out. So this was an SICS with iris hooks, And this was extremely rigid, extremely sort of friable iris, very thinned out iris. So again, so here I would sort of prefer, now I would prefer to use 5 iris hooks in most SICS. And one can remove the superior iris hooks when one is removing this. Here I didn't. But you can see, because of the, how thin the iris was, the state of the iris after that, it doesn't matter. It was like complicated cataract, at least you can see the fundus after that. This was another complicated cataract, and the difference here is that there is a sort of a membrane over the pupillary area also. So you can see it's not a rhexis that I'm doing, I'm actually removing the pupillary membrane. And that is very important before, doing that. So I could have actually stretched the iris a bit more with 2 hooks. I didn't do that. And because I'm doing that, you'll notice later that I've sort of damaged the anterior capsule in one place. And I'm actually not expanding the iris, the pupil fully. Because if it's a phaco, you really don't need to. So you can do it stage-wise. Here I wanted it, under the phaco wound, I wanted it to be expanded a bit more. But then I realized once I do this, that I've sort of torn the anterior capsule, so I wanted to expand the pupil fully to be able to do a rhexis from that point, where I've sort of torn the rhexis, which is here. So once you have any problem, there is, you shouldn't hesitate. You should just make your visualization easy. And very, very soft cataract. So anyway, that is... but if I had sort of not expanded it fully and let the tear be, then probably I would have had problems. This is basically, how you make the incisions and how you remove the, so this is the traditional way. So it's at the limbus. Making them slightly more posterior, your iris is not lifted up, but yes, there is a problem that, so this has to go into the sclera because your phaco wound will come at the limbus. The others can also go through the sclera. If I suspect that I may need, there may be, so again, just rotate it and it comes out. So no struggle at all. I find some of my fellows really struggling to remove these. It's very simple. You can actually point the hook upwards also and it becomes even easier. But just release it, rotate it and just push it a little forward or backwards, whatever the case may be, and it comes out. This was another case where the pupil was really small and had no idea what the lens was behind it. And then I realized when I'm doing the rhexis that the lens is moving. So in this case, I move the hooks from the iris margin to the rhexis margin. And here I cut make the hook shorter so that it doesn't sort of interfere with the eye moving. And then, so this was a phaco, SICS, but in these cases, probably I would prefer to do a phaco when there is a little bit of subluxation. So this was probably the first pupillary dilating device that was described. It's still very useful to use. And reuse hooks are wider and tend to cause more capsular damage. And do not expand the pupil to beyond 6 millimeters if it's a phaco. So then it looks fairly all right after you remove the hooks also. And this may not be practical for a manual SICS, where you need to, of course, expand it limbus to limbus. Otherwise, you cannot really dislocate the nucleus out. And sphincter price is just a small price to pay for safe surgery. And unlike other pupillary dilating devices, iris hooks, as you saw, can be used to support the capsular bag intraoperatively. Thank you.
Thank you very much, Sudeep. Wonderful tips on iris hooks, and I can see people are, still taking pictures over here. So that means iris hooks also, there is a lot of learning curve, and there is a lot to learn. There are finer points which Sudeep dealt with. He'll be here for